Hello, welcome to your online lecture for the pathologies that occur to the thorax and abdomen. Today, in this online lecture, we're going to focus on the thorax and anatomy to the thorax and injuries to the thorax, and then we'll separate abdominal anatomy and abdominal injuries. And so that hopefully will shorten this lecture. Let's hope. So since the central theme of this particular online lecture is the thorax, I think it's important to really start thinking about what is the major role of the thorax in general, right? Like structurally and functionally. Why do we have this bony anatomical structure that sits right in the central part of our body? And the major reason for that is it is a cage-like structure, right? That's going to protect some of our vital organs, two of them really, the heart and the lungs, right? So that cage kind of surrounds and encases and protects the heart and the lungs from traumatic injury or injury in general. But then just as an overall point, what we can see here is that the thoracic cavity also serves as a major site for muscular attachment, specifically for muscles that kind of emanate from the upper extremities, the head, the neck, and the vertebral column. And in some ways, if we look even lower, there are some muscles that come off of the pelvis and have an attachment to the thorax. So we can see that the thorax in general is a major attachment site for muscles, but then also plays a major role in protecting at least two of our very vital organs, the heart and the lung. So any injury to this anatomical structure, and it can be catastrophic, right? Most often injuries that occur to the thorax are going to be traumatic in nature, right? So we could think of blunt force trauma, for example, maybe even a gunshot wound or a stab wound. But most often, if we have dysfunction or injury at this joint, it is most often going to be traumatic in nature. So let's dive deep into the lecture for the thorax. So the first step to kind of understanding thorax anatomy is really to find like what are its boundaries or limits, right? So ultimately we have the thoracic cavity or the chest wall, which is going to be the most anterior portion of the thoracic cavity. And if we wanted to point to that, that would be all of these structures here, which make up the anterior component of that, right? More laterally, what we have are the kind of bodies of the ribs, both ribs 1 all the way down to rib 12, which we'll talk about in just a second. And then posteriorly, it's going to be all of the spinal processes posterior on the posterior spine that make up the posterior component. These structures all together make up the anatomical structure known as the thorax. But in addition to that, what we also see is that we have two very key and important anatomical structures. This first opening is known as the superior thoracic aperture, and then inferiorly we have the inferior thoracic aperture. Each of these apertures are openings. That would be another word for aperture. They're openings, right? The superior aperture opens towards the neck, right? So you can see that here it opens up to the neck. Another way to say that is it kind of creates a connection between the thoracic elements and the cervical elements and creates that connection piece. But more importantly, when we think about apertures, we have to think about what forms them, what structures are responsible for creating that opening. And so anteriorly, that is going to be the manubrium. And then laterally, it's going to be the body of ribs or rib 1 on each side. And then posteriorly, it's going to be the spinal body of thoracic spine number 1, right? And so we have those structures coming together to create this very important aperture, which again is a connection piece between the thorax and the cervical spine. And then inferiorly, as I mentioned, we have that inferior thoracic aperture, right? And you can see here that it is formed by the diaphragm, which is important because the diaphragm is an anatomical structure that's important for respiration, but even probably more important, it also is responsible for separating the thorax from the abdominal cavity. So we have these two cavities, right? Thoracic cavity, abdominal cavity, which sit relatively close to one another. And the one thing separating those two cavities is going to be that diaphragm, which sits right on the base of that inferior thoracic aperture. So that's the first part of anatomy. Now that we understand that there are openings, now that we understand the boundaries, right, of the thoracic cavity, now we can move deeper into the anatomy. So as I alluded to earlier, the thorax cavity in general protects the internal organs. Those two probably vital internal organs are going to be the lungs, right? And then we talked about the heart, right? So at the heart of what the thorax cavity is really built to do, it's really built to protect those two key vital internal organs. And so knowing what it's comprised of, knowing what injuries have the potential to cause further injury to the cardiac region, right, or the pleural cavity becomes extremely important. Anytime a patient takes a blow to the thoracic cavity, you should be concerned most definitely with bony structures. But even deep to that, we probably our assessment of the thoracic cavity should also include a pleural assessment and a cardiac assessment as well. And we'll walk through that in lab, how to auscultate to make sure that our lungs and our heart are in good working condition. So let's start with the meat of the thorax. In other words, the anatomical structures that are responsible for creating kind of the foundation of the thorax are the ribs. And so you have really three different sets of ribs, or three different categories of ribs. That's the way that I would say it. You have the true ribs, the false ribs, and the floating ribs. And each of them gets their name by the way that they attach to the anterior aspect, right? So the anterior aspect of that thorax. Your true ribs, which are going to be ribs 1 through 7. I'll circle them on this image here. So your true ribs are going to be 1 through 7. And so what we know about ribs 1 through 7, if we look at them, is that they directly have an attachment site to the sternum. Like they directly attach to the sternum. And so then our false ribs get their name false ribs because they don't have a direct attachment to the sternum, right? And I'm going to hopefully show you that or illustrate that here in this image. So when we look at ribs 8 through 10, you have your ribs here and here, but do you see how they indirectly attach to the sternum via true rib number 7's costal cartilage, right? So they don't have a true direct attachment to the sternum. And so for that reason, they are called false ribs. Ribs 11 through 12, on the other hand, why do you think they're called false ribs? What do you notice about them down here? They have no direct attachment to the anterior aspect of the sternum. You got it, right? And so our true ribs are ribs in which there is a direct articulation directly to the sternum. And we can see that, right, in this blue kind of anatomical structure here. This blue anatomical structure right here is known as the costal cartilage. Costal cartilage, see that here? The costal cartilage is an extremely important anatomical structure because it's where the ribs, once they lose their bony integrity, have a way to insert onto the anterior aspect of the sternum, right? And so any injury or damage to the costal cartilage, and the ribs, at least the true ribs, lose their direct connection to the anterior sternum. Some concerns that we have with injury to the costal cartilage. What do you think? Great. If you said we know that costal cartilage lacks blood flow, right? So what do we know about anatomical structures that lack blood flow or are not rich in blood flow? They take a lot longer to heal themselves. The other thing that we know about costal cartilage is that with age, obviously the integrity, the strength of that costal cartilage will decline over time, making the patient at more risk for injury. So moving back to anatomy, just as a review, we have ribs 1 through 7. Those are true ribs, and those are true ribs because they have a direct attachment to this anatomical structure here known as what? The sternal body. Then we have distal to that, we have what we call as the xiphoid process. And the xiphoid process is extremely important anatomical structure because when we perform CPR, one of the reasons we want to be in the center of the chest here and not lower is because we can fracture off the xiphoid process, right? So this is a major anatomical landmark to avoid when you're performing CPR, because what it will do, and you can see its position, is if you compress on that xiphoid process, it can fracture off posteriorly and puncture the heart and cause instantaneous death. So we want to be very, very careful. But in order for me to stay ordered and organized, the sternum is kind of made up of 3 key components, anterior sternum. It's going to be made up of the manubrium, right? Which we already said does what? Forms the most anterior portion of what? What's this right here? Right, the superior aperture, right? The other key anatomical structures right here, it's going to be the sternal body, and then you have the xiphoid process. So these three anatomical structures make up the most anterior component of the anatomy of the sternum. So all in all, if we look at this, we have 12 bony structures that are laterally positioned, right, to make up the thoracic cavity and protect us from kind of lateral forces. And anteriorly, we have the costal cartilage, which is a connection piece, right, and creates the connection piece between the bony ribs into insertion onto the anterior sternum. And all of these anatomical structures come together to really create protection for our lungs and our heart. So anytime there's injury, we're really concerned about respiratory, circulatory pathologies. So we already said that one of the main functions of the ribs is really to protect the internal and vital organs, really the heart and the lungs. And then the second function of the rib cage is really truly to kind of be this landing space for attachments of muscles from the neck, the thorax, upper abdomen, and the back. Additionally, we talked about those floating ribs on the previous slide, and we said they don't have an anterior attachment to the sternum. And this actually frees them up and the rib cage up enough during really inhalation to allow the rib cage to expand, and then during exhalation to allow that rib cage to return to a normal resting place. So ultimately, those false and floating ribs are key in increasing the amount of mobility that we have within the thoracic spine. So there are three muscles that are really going to be responsible for allowing us to inspire and exhale. And those muscles, major muscles of respiration, are going to be the external intercostal, the internal intercostals, and the diaphragm. We already talked about the diaphragm a little bit in that it makes up the inferior aperture of the thorax and separates the thorax from the abdominal cavity. So that's the major role. Its other major role is really to contract and cause expansion of the thorax to make way for the air that we are inhaling. And on this image here, what I really wanted to bring home is really the directionality of the fibers of the internal and external intercostal. So the external intercostal, the vibration is going to be towards the sternum. We can see that here. It's going to be more superficial in nature than if we were to transect and reflect. Then what we would see deep to that would be the internal intercostal muscles. And those muscles actually move towards the lateral side of the rib cage. In terms of their attachment, it's very tricky, right? So what we would say essentially is that the superior attachment, so we can see that here, whether it is internal or external intercostal, the superior attachment is going to attach to the inferior border of the rib above it, right? And then the distal attachment or inferior attachment is going to be to the superior portion of the rib below it. So you have these attachment sites. And if we move to the next slide, what we'll see here are key things. So in terms of inspiration, our external intercostals are going to be most active. In other words, when we inhale, those external intercostal muscles along with the diaphragm contract. When they do that, you can see in this image here, they're going to cause the chest wall to expand. And that when that chest wall expands, guess what else is able to expand as well? The lungs, right? So that all makes sense. But can you see in an injury model where if we have a strain to the external intercostals, how we may not be able to expand the chest wall as much, which means we may not be able to get as much air in during inhalation. On the other side of breathing, we inhale, but then we also have to do what? We have to exhale. So when we exhale, those external intercostal muscles relax. And then what you have are the internal intercostal muscles becoming more active. In other words, those internal intercostals and the abdominal muscles will, the internal intercostal muscles will contract to allow the muscle, the rib cage, to kind of move back to its resting position. However, if we have forced exhalation, then the abdominal muscles, particularly the rectus abdominis, which you can see here, will also contract in that instance, right? So ultimately, when we exhale, those internal intercostal muscles are way active, right? And so when they contract, as you can see, they're going to draw the thorax down into a return to rest position that will then cause the lungs to deflate, and we're back to normal all over again. So any injury to the external intercostals or internal intercostals, and we have implications for respiration, or we will have a change in the respiratory pattern, right? And we can think about this from a hyperventilation standpoint. When a patient's hyperventilating, right, are they struggling to get air in, or are they struggling to get air out? What do you think? Typically, they're struggling to get air in. And so which muscle do you think would be contracting most often, or maybe spasming? It could be both, right? It just depends on what the patient is struggling to do. So as clinicians, it becomes important to understand how to assess for pathology to the lungs, right? To breathing, to respiration, and to the heart as well. And so in lab, what we will be doing is auscultating each of these signs and or sites. And so this would be, if we're assessing for a lung pathology, this is a posterior spine, and these sites would be consistent from left to right, right? So I'm going to draw those in so there is no confusion that, in fact, yes, we want to auscultate one side and then move to the next, and then move to the next spot and on to the next. And we'll do that in a sequential pattern. When we listen or when we auscultate, essentially what we're doing is just listening. As athletic trainers, what we would be listening for is any abnormality in breathing. We won't be able to diagnose the breathing pathology. We just want to know, do we hear air moving through the lungs? And if not, do we need to refer it out? On the left-hand side, this would be an assessment of the heart, right, or the cardiac. So these are the 5 auscultation points that we should use to assess heart abnormalities. Again, we will do this together as a class, but I just wanted to bring this to your attention. In this PowerPoint, I have embedded 2 different videos on ways to percuss and auscultate the pleural cavity and the cardiac cavity. So please take time to review those. And then for our abdominal lecture, we'll get there eventually. You'll be called to listen to this video where it teaches you how to kind of palpate and auscultate the abdomen in particular for any type of injury to the internal organs. So now we're on to muscular anatomy of the thorax. Most of the muscles that we are going to focus in on are going to be to the posterior thoracic spine. We'll certainly talk through anterior musculature, but a lot of the musculature on the anterior portion of the thoracic cavity will cover in the glenohumeral joint or in the elbow, wrist, and hand when we get there. So our next stop is really in the area of muscular anatomy. So I'm hoping that this is a review. So we have our traps, right? And if we're doing this right, what we would say is we have our descending part here, we have our transverse part here, and we have our ascending part here. So ascending, transverse, descending traps, right? As a review. So I'm going to erase those and then look at them as a whole muscle group. As a whole, they are either going to elevate, so that descending part will elevate the scapula. That transverse part will, what will it do? Retract, good. And then that ascending part will do what? It's going to depress the scapula. And so each of these, right, so depress the scapula, we can see that even though we always refer to the traps as one muscle group, really need to refer to them kind of independently and distinctly, because dysfunction to the descending trap, for example, may mean that the patient won't be able to elevate the scap, right? Whereas a dysfunction to the ascending portion of the trap may mean that they have a terrible time, a terrible time kind of depressing the scapula. And so these all have different implications for the glenohumeral joint, but then also for the thoracic spine, right? In terms of their attachments, we know that the descending trap is going to come up and proximally attached to like the nuchal line, and maybe even have some cervical spine insertion. And then distally, what we know is that the ascending trap is going to come down and have attachments to T7 through T12 in terms of anatomy, but knowing their major role will become extremely important. The next muscle will just keep moving laterally is the deltoid muscle. We know that the deltoid is broken up into 3 different deltoids, right? We have the anterior, middle, and posterior deltoid. As a whole, we would say that the AB duct, the glenohumeral joint. But if we're being very, very kind of specific, what I would say is the kind of anterior portion will help with glenohumeral flexion. That middle section is going to AB duct purely. And that posterior portion is going to do what? Great. It's going to extend the glenohumeral joint. So that's going to be the deltoid muscle. You can see that there. We'll palpate that in lab. And then next, what we have are going to be the lats, right? We can see them here. The lats, probably easiest to dissect. The lats will extend into what we call is the thoracolumbar fascia. This plays a major role in SI joint stability and function. But the lats in general, what do they do? Like, why are they so important? They play a major role in humeral movement, right? Not only do they extend the humerus, they also adduct the humerus, right? And then they internally rotate that humerus as well. So we can see, again, major role in terms of the role at the humerus. But why are we talking about this muscle in the thoracic spine? Someone tell me. You don't want to tell me? Great, because it has attachments to the thoracic cavity, right? We can kind of see that there, that in fact it's going to attach to the inferior 6 thoracic vertebrae, right? So if we look at how many vertebrae are actually within the thoracic spine, it's 12. It's going to attach to from T6 to T12. So again, it has a thoracic spine attachment that's going to be responsible for creating a stability about the thoracic spine itself. So that's the reason we're talking about a humeral movement in the thoracic spine. So any compromise to the thoracic spine, can we have issues in the glenohumeral joint? Absolutely. Hopefully you are seeing that here in this image. The next muscle that we're going to talk about on this image is going to be the serratus posterior, which is here. It has some overlap to the thoracolumbar fascia. Its major role in the body is good. If you said that they assist with force expiration, you'd be correct. So its major role is assisting in respiration in particular. Anytime we have force expiration, that serratus posterior inferior is going to contract. And we can see in this image that it kind of originates off of T11-ish area. So T11 will go back down into the lumbar spine about L2, but then also has direct attachments to ribs 9 through 12. So again, it would make sense that it does play a role in respiration because it has direct contact to ribs 9 through 12. On the other side of this chart, we have the muscles of the deep back. The muscles of the deep back are most often known as the erector spinae muscles, right? So we treat them as a whole. So we can see the muscles of the erector spinae. Remember that whole I kind of love spaghetti. And so we'll review those really quickly. So I've marked them as longissimus, right? Where are we? Iliocostalis, closest to the rib cage. You have longissimus, which is going to be here, and then you have spinalis, which is going to be closer to the spine, right? So you have iliocostalis, love, longissimus, spaghetti, spinalis. And you can see them beautifully depicted here as well in the muscles of the erector spinae group, right? So iliocostalis, longissimus, spinalis. And so we can see that those come together. And what's their major role? What do you think their major role is? Great. Major role is to assist in stability of the spine by creating a spinal extension at the spine. So we can see that there are lots of muscles that kind of land on the posterior thoracic spine. I've discussed the ones that are going to be key for you as athletic training students. Some of you may be wondering, why does Dr. Cosby have some of the gluteal muscles on the a lecture for the thoracic spine? What would be the reason? Major reason is they're going to stabilize. Remember, they have to stabilize that hip onto the pelvis. And then we can see right in here that the thoracolumbar fascia is going to come down and insert onto the posterior iliac spine. And so there's a connection piece, right? There's a connection piece between the thoracic spine posteriorly and the ilium or the iliac crest. We will do this in lab, but I thought it was important to just to put this image in here so you can see the things that we're actually going to be palpating. A key anatomical landmark is going to be that occiput, the base of the occiput, and the nuchal line here. We'll have transverse processes that we'll be palpating really for all of the thoracic and cervical spine. We have the spinous process, which is going to be the most bony process that will pop out at us. It will be easy to palpate. And then we'll get deep in there with the supraspinous ligaments. These are the ligaments that get injured oftentimes when we think about whiplash. We already talked about the trapezius muscles themselves, the levator scapulae, which I did not bring up in the last PowerPoint, but it is this muscle here. The levator scapulae is an extremely important muscle, also helps with elevation of the scapula, all of the scapular muscles. And then last but definitely not least, let's see if I can find it, we'll talk about the costal vertebral junction, which is oftentimes when we think about like a rib dislocation, it's oftentimes that it happens at what we call is the costal vertebral junction, which is where the rib is inserting onto the actual spine itself. So as we move into pathologies of the thoracic spine, I kind of wanted to group them because I think it makes it easier. There are basically 7 types of pathology that will plague the thoracic spine. So that's not a whole bunch, right, when you think about it. Remember, the thoracic spine in general is relatively well protected by all of the muscles that we just talked about. And really the risk of injury is very, very rare, unless, of course, it's trauma-induced, right? So the types or categories that I place them into are fractures, which most often happen as a result of direct trauma, mostly compressional forces. You'll have muscle strains or fascial pathologies, ligament sprains and strains, and then you'll have changes in the shape of the spine, so hyperkyphosis or scoliotic pathology. You can also have a patient develop what we call degenerative disc disease or joint disease. The reality is, though, that this doesn't happen very often in the T-spine. The major reason it doesn't happen in the T-spine is because there isn't as much mobility as there is in the cervical spine, where we see a lot of the disc pathologies, but it certainly can happen. You have what we call is Sherman's disease, and we'll discuss this, but this is a juvenile disease that manifests itself around the ages of 13 to 16. Disc herniation, nerve impingement certainly can happen, but again, rare in this particular spine. You've got spinal stenosis, which is like where you have the central portion of the spinal body narrowing, which causes degeneration and neurological signs and symptoms going down the spine. So we're going to break each of these down, but these are the typical categories that can plague the spine. All right, so now the fun begins. We've gotten through anatomy. I hope that was helpful and you have a better understanding of this. So now what we're going to talk about are pathologies. The first and probably most common type of pathology to the thorax is going to be a rib fracture. Most often this occurs as a result of a direct blow to the thorax in some region. Typically, if the blow is forceful enough, the fracture will happen right at the point of contact. So this will be a huge kind of history question, right? So history question, where did you take the blow, right? Did the blow occur? This will help you determine 90% of the time where the actual fracture it is, right? There are some times, however, where a rib fracture can occur as a result of an indirect trauma. So most often this is going to be some type of compressional force that occurred to the rib, like hugging, for example, would cause a fracturing of the rib, or a violent muscle contraction. So lots of coughing. So I'll go down here. Coughing, laughing, which causes a violent muscular contraction, particularly of the external intercostals or of the diaphragm, can be, if it's forceful enough, can cause a fracture. And then last but definitely not least, you can have a stress fracture from an overuse injury. So I like to think a lot of times of like, what are things that would cause repeated blows to the thorax cavity? We can think of boxing. We can think of MMA, for example. A gymnast, believe it or not, particularly on the beam and the bars where they hit their anterior thorax oftentimes. So you certainly can have a stress fracture of the thorax cavity. So what are the signs and symptoms associated with a rib fracture? Patient's going to be tender to palpation at the actual fracture site, and they will have pain with inhalation. And if we were to go back a few slides, remember what we said, those external intercostals are contracting along with the diaphragm to do what during inhalation? Right, expand the rib cage. So anytime they inhale, there's an expansion of the rib cage, which indirectly causes pain. And then they're going to have pain with what we call is an anterior to posterior compression test and a lateral compression test. And I'll show you that on the next slide. So what do we do for these individuals? Referral. You all know me. I'm pretty conservative when it comes to treating most things. But because the ribs, remember the thorax in particular, is protecting which two vital organs? Right, the heart and the lungs. So anytime you have a rib fracture, you want to ensure that the rib did not fracture posteriorly and cause pathology such as a pneumothorax or a HEMOTHORAX or any heart damage. So you refer them out. You're going to swath them, which means you're going to wrap the injured, the arm on the injured side to that part of the rib cage. And what that will do is by wrapping them tightly, you reduce the amount of rib motion that you can actually get. In terms of how long they'll be out for, it depends, but about 3 to 4 weeks. And then the concern, like I said, would be whether or not that patient has a hemothorax, which would be a rib fracturing posteriorly and causing bleeding within the pleural cavity, or a pneumothorax, which means the rib fractured posteriorly and now air is allowed to get into the pleural cavity. So we want to rule out those items, which is why we refer out when we have a rib fracture. So this is the compression test that I was talking about. You can have an anterior to posterior compression test, or you can see here what we call is a lateral compression test. Each of these tests will cause pain at the site of the fracture. So if this is positive, we would refer out for further imaging to rule in or rule out a fracture of the rib cage. So our next pathology is going to be a costochondral fracture or separation. So remember we said that the rib cage, right, here are the ribs, but then we have this blue structure here, which is known as the costal portion of the rib, right? And so this is the part that doesn't get as much blood flow, so it may take a little bit longer to heal itself, right? It's also the connecting piece for, remember, ribs. Which ribs? Good. You said 8 and 10 because 11 and 12 are free floating. So you can see that here it's coming together to bring an attachment point to the anterior aspect of the ribs. So the etiology is going to be the same. Most often it's direct blunt force trauma or some type of compressional injury, which causes damage to the costochondral junction. And so what does this mean exactly? What do I mean when I say costochondral? So what I'm saying is that you have a fracture that occurs not to the actual bone, but to the cartilage portion. And that can happen in like 2 different places. It can either happen here, right at the anterior attachment site of the rib to the sternum, that's costal cartilage, or it can happen where the rib inserts onto the cartilage itself. So there are 2 different places. The implications for the injuries and where they occur are going to be different. So let's talk through that. If I have an injury at the costal cartilage, costochondral junction, and it occurs closer to the sternum, that rib may be able to free float a little bit more, right? And so inhalation is going to be impacted because every time you inhale, you might feel that rib kind of move in an anterior position as the chest cavity expands. Injury to the, I guess we'll say, most lateral anterior part of the costochondral. What that means is you'll feel the rib as you're inhaling kind of poke out at you on the lateral side. So signs and symptoms will be similar. It's just a matter of where we get movement, right? They typically say that injuries to the costochondral junction closer to the sternum are a tad bit more painful because it involves sternal chest pain as well. Oftentimes, it can present like anterior chest pain, particularly if it's this type of fracture. And so you want to refer out just to be safe and make sure you don't have any pleural or cardiac issues, right? So what are the signs and symptoms? I've kind of alluded to them a little bit. You have some sort of deformity at the costochondral junction, so either here and or here. They're going to have pain with inspiration, as I said, because when you have this disconnect between the two anatomical structures, there will be movement or gliding across and cause kind of a crepitus or a pain. That's why I say crepitus. And then this is going to take a lot longer to heal itself, right? A traditional rib fracture, we said 3 to 4 weeks, but with a costochondral injury, it takes a lot longer, and that has to do with a lack of blood flow, right? There just isn't as much blood flow. The other thing that we typically see is this is a more active injury. In other words, it's always going to be on, whether you're exhaling or inhaling over time. So the treatment is, for the most part, the same, right? We're going to swath them. We're going to try to reduce the rib cage from expanding over time. Okay, so we have pneumothorax, which I kind of alluded to in the rib fracture slide and said that you can have a pneumothorax that occurs as a result of injury to a rib. But more specifically, there are types, right? So first type of pneumothorax is going to be a traumatic pneumothorax. What this means is you have an injury to the rib. The rib, maybe it subluxes posteriorly, and as a result, it disrupts the pleural cavity lining. And so then air is allowed to enter into the pleural cavity. And this air, it disrupts the lungs' ability to expand or draw oxygen in, right? So there's this air applying pressure to the lung now as a result. And so it can't expand, which means we can't draw oxygen in. And so we have this decrease in oxygen intake, which reduces the amount of oxygen being delivered to the bloodstream, right? You're imagining, okay, if I'm not getting enough oxygen in my bloodstream, I'm not able to feed the musculoskeletal system, the brain, the lungs, the hearts, all of the things that need oxygen to thrive. And so then the patient enters into what we call as respiratory distress, right? Where they might start breathing faster to bring in more oxygen to be circulated to the rest of the body. So that would be traumatic. I take a blow, my rib fractures posteriorly. As a result, I rupture the pleural cavity lining. Air is allowed to go in. Air disrupts the ability of the lung to expand. You also have a situation where you can have a spontaneous pneumothorax where the lung collapses and there wasn't any blow, so atraumatic in nature. This most often is related to something called a bleb. So a bleb is like a sac that sits on kind of the lungs, and that sac is either filled with air and or fluid, and that sac literally just ruptures, and as a result, air is allowed to leak into the pleural cavity, and then the same thing happens, right? That air leaks into the cavity, the pleural cavity, places pressure on the lung can't expand, and so we have a lack of what? A lack of oxygen to the area, and the same thing happens. We breathe faster, right, to bring in more air. Probably most life-threatening is going to be a tension pneumothorax. This can develop most often as a result of a spontaneous pneumothorax. So we have this bleb rupture, we have air going into the pleural cavity, but in a tension pneumothorax, the wound doesn't heal, right? And so as a result, that air that enters the cavity, it gets trapped. It does not exit naturally. And so it starts to place pressure on the lung, causing the lung to collapse. And so if we don't do something about this, right, if we don't remove the air, if we don't release the pressure, then what we can see is that it can have an impact, that constant tension, why we call it tension, on the lung. It indirectly will start to impact the heart and the major arteries, leading to death. So we want to be careful. Anytime we have a rib injury, anytime we suspect a pneumothorax, whether it's traumatic or spontaneous, we always want to get it checked to make sure that air is able to leave the body, because if air can't leave that pleural cavity, that tension will then indirectly subsequently impact the heart, the lungs, and the major arteries, particularly the aorta, for example, which might be delivering blood and oxygenated blood to the rest of the body. So very important pathologies. If you're unsure, just refer out. It's one of the reasons that we say when you have a rib fracture, you're supposed to refer out anyway. But the etiology of it is anything that introduces air between the parietal and visceral pleura can cause a pneumothorax. And I kind of described all of that already, but most often traumatic in nature, right? It can be a blow to the rib, but it certainly could be a gunshot wound or a knife wound. When I say puncture to the chest wall, that's what I'm referring to. And then you have the spontaneous, which is idiopathic, right? Most often occur in tall individuals because their tissue is thinner, and so they're able to develop the blebs. And so by that, I'm referring to those with Marfan syndrome. You can also have a secondary spontaneous rib injury, which is as a result, spontaneous pneumothorax, which is a result of disease. So cancer or congestive heart failure where air or fluid is allowed to enter into the parietal and visceral pleura. So as I talked about the tension pneumothorax, this is a good way to kind of bring it home. I'm a visual person, right? So we have this either spontaneous pneumothorax or tension pneumothorax, and air is allowed to enter. And what you can see, this is a kind of somewhat of a healthy lung, right? You can see how the lung on the side where the air is, right, is making that lung shrink. But in a tension pneumothorax, as air is allowed to enter and not leave, we start to see pressure, right? Pressure on the heart, pressure on the arteries and the veins. And then we also start to see a collapsing of the lung on the other side, or a pressure. And so this is why it's a medical emergency, because we already have the shrinking of the trauma side lung, but then we also start to see compression on more important anatomical structures. So this can actually cause death. So again, if you're uncertain, just refer out, and we'll do a chest x-ray and then hopefully some type of surgical intervention to remove the air slowly. And I'll tell you about an example in class that I had in football. So for review, this is pneumothorax. This is most often happens as a result of trauma. That lung is going to collapse because there's pressure, right, in the area from the air that enters into the pleural space. And so we see the mediastinum, which is like the middle compartment, which houses the heart. It will shift away from the area. So I'm going to go back here. You'll see it here, right? So we have air coming in, and you'll start to see everything shift away from the site of air. So I'm moving back to here so we can see that. So in terms of signs and symptoms, the patient's going to complain of sharp chest pain. Most often with inhalation, they'll complain of pain and shortness of breath. They may or may not have breath sounds when you auscultate. So we'll talk about that, absent breath sounds. If it's a tension pneumothorax, then they may have tachycardia, and the key clinical sign symptom would be to assess their blood pressure if you can. And if there's low blood pressure associated with that, then we certainly should suspect a pneumothorax. So what do we do for them? It's going to be an x-ray, a chest x-ray for a simple pneumothorax, simple, not complicated, not tension. We can do some type of O2 and then maybe a chest tube. For a tension pneumothorax, most often they're going to cut through both internal, external intercostals, spread the two ribs, the second intercostal space, and they're going to create what we call is a vacuum of, sealing effect, and then they'll seal that opening with a sterile dressing. And this takes a long time. I would say 4 to 6 weeks before you remove air. It's a slow process because you don't want to disrupt the pressure balance within the pleural cavity. So with the spontaneous, these are a little bit, or the tension pneumothorax, these are a little bit scarier, right? Because you have a bleb rupture, and then all of a sudden the patient complains of anterior chest pain, and you have no idea why, right? One thing to be aware of is that divers are most susceptible to spontaneous pneumothorax, and part of that is because they're diving so deep, right, in the water that the negative pressure is compromised, right? As the diver holds their breath and kind of comes up, that kind of stretches the tissue and then causes the bleb to rupture and allows air to leak into that pleural space. And it'll interrupt that negative pressure that inflates the lungs, right? So the hard part is that blebs are hard to detect. You typically can't detect them until they actually rupture. And then when the patient goes in for the chest x-ray, maybe even CT or MR, that you can actually see those. The biggest thing is that the lung is compressed, right? Which is the same as a pneumothorax. But the concern with the tension thorax is the implications for the heart, right? So if we were to go back here, the implications for the compression on the heart, which is also sitting in that space, it will start to get compressed, limiting its ability to circulate blood, to pump, all of those awesome things. So signs and symptoms, sharp pain on the affected side. So it's going to be one-sided. Their patient's going to be cyanotic blue, right, or ashen if they're dark or complex, and they're going to have that rapid, shallow breathing to kind of bring in the oxygen that the body wished that they actually had. A hemothorax is very similar. The difference is that there's some type of bleeding that occurs. So this is what's considered a punctured lung, not a collapsed lung. This is where blood is actually allowed to enter into the pleural cavity. Patient's going to complain of pain, dyspnea. Major differential between a pneumothorax and a hemothorax is going to be the patient coughing up blood. So what I typically do if I suspect some type of pneumo or hemothorax is just have the patient cough into some type of tissue to see if there's blood. Most often, if there is no blood, you can rule out a hemothorax. Patient's going to have lower blood pressure, and that's because they're losing blood internally, right, into the pleural cavity, and they will eventually go into shock. So this is a patient, when we look at pneumo versus hemo, they're going to deteriorate a lot quicker or more rapidly, but the biggest differential here is going to be coughing up that frothy blood. So this is a tracheocentesis. Tracheocentesis is most often used to drain fluid from the pleural cavity or areas in the cardiac where you need to drain fluid slowly. Essentially what they're going to do is insert some sort of small vacuum into the pleural space or pleural cavity. And what you can see is that they will slowly pull out the fluid or the air. And this is a very slow process, as I mentioned. I've seen it done in the emergent setting. It's a very slow process. Like I said, it could take upwards of 4 to 6 weeks just to remove the fluid. You don't want to do it too quick, because if you do it too quick, then you disrupt the pressure system. And so you want to be very, very careful when you do that. Most often, the patient is going to be in a seated position when they are inserting that. If the patient can't sit, then they'll lay them on the opposite side and they'll insert that. Is the patient usually numb when they do this? Absolutely. Okay, those are most of the pathologies in the thorax. So that concludes the lecture for thorax pathologies. I hope this was helpful.